Assalamualaikum warahmatullahi ta'ala wabarakatuh. Happy World Kidney Day, which will be happening tomorrow. So Ramadan Kareem to everybody, all Muslims who are fasting. So today is another session of Breakfast at UMHealth, which will be chaired by me. My name is Ahmad Hafiz. I'm currently the consultant nephrologist in UMMC. And together with me, we have two great speakers, and also among my colleagues, Dr. Tay Sok Kun and Associate Professor Dr. Karmila binti Bakar. Our talk today is mainly revolving around nephrology. And this is in conjunction with World Kidney Day, which will be happening tomorrow, which is the second Thursday of every March. So the World Kidney Day this year, the theme for it is basically, are your kidneys okay? Detect early, protect kidney health. So the latest statistic in NHMS puts the CKD prevalence is higher than diabetic prevalence. So CKD prevalence a couple of years ago was 15.5%, while the diabetic prevalence in recent years is about 15%. But regardless, both are important, and CKD are affecting 800 million people worldwide. Although CKD has been associated with diabetes and hypertension, not to forget that CKD can also be caused by these rare diseases, and especially diseases in children. So today, specifically, we are going to hear from two of our panelists talking about diseases which is not so common in adult, and both of them are pediatrician, although we are working closely together. So let me introduce you to our first speaker, Associate Professor Dr. Karmila binti Bakar. She's a pediatrician, and she completed her undergraduate training. Cannot tell the year, Karmila. Okay, masters in pediatrics, and now very interested in rare diseases in children. So without further ado, Professor Karmila, let the floor be yours.
Hi, Assalamualaikum and good morning, lecturers, students, ladies and gentlemen. My name is Karmila and thanks for the introduction, Hafiz. Today, I'm going to talk about rare pediatric kidney disease. So some of you might wonder whether children and adults experience similar kidney disease. Well, I would say not all the time, but it is overlapping. But most of the time, it is related to lifestyle, but children, they are born with it. Pediatric kidney disease is defined as any condition or disorder that affects the kidneys in children, typically under the age of 18. There are various types of pediatric kidney diseases. Number one is the congenital anomaly or structural problem of the kidneys. It is called Charcot. It can be a refluxing system, or it can be obstruction like pelvic ureteric junction obstruction or vesicoureteric junction obstruction. It can be acquired after an episode of infection. Sorry, just now was obstruction. It can be acquired after an episode of infection like post-strep GN or HSP. It can be inherited like polycystic kidney disease or Alport syndrome. What are the significance of knowing about pediatric kidney disease? Early intervention is crucial. In children with Charcot, example, if they have multiple episodes of infection, we need to stop it from happening. Because we need to prevent the complications like kidney scarring. It may have impact on growth and development, so we need to make sure that the acid base and electrolytes are within the normal range. It is a potential for chronic kidney disease, so we need to stop or delay the progression, and we need to ensure quality of life in this kind of children so that they may attend school and involve in other activities. What about prevalence of kidney disease in children? We are lacking of comprehensive national data on pediatric kidney disease, but available studies indicate an increasing trend among children and adolescents. Why is that so? Because of the new pandemic, more children become obese recently. Data from the MDTR in 2016 revealed a rise in the number of patients under 20 requiring kidney replacement therapy from 680 in 2007 to 1,000 in 2016. It does not mean that more children ended up with end-stage kidney disease, but it's just saying that there are better service provision in Malaysia. This table actually showed us primary renal disease in children with end-stage kidney disease. Surprisingly, glomerulonephritis is the commonest cause of ESKD in children. If you compare this data with other developed countries, their commonest cause is Kakut. So maybe there is a different genetic composition, or because we are not really at par with them yet, we don't offer neonatal or infantile dialysis. So overview of rare pediatric kidney disease. Example of rare diseases in children. Number one is polycystic kidney disease. There are two types, autosomal dominant PKD or autosomal recessive PKD. Autosomal dominant, the prevalence is 1 in 400 to 1 in 1,000, happen in teenage years for pediatrics. Autosomal recessive, prevalence is much rarer, 1 in 20,000 to 1 in 40,000. It presents in infancy or early childhood. Next is Alport syndrome. It does not only affect the kidney, but also the ears and the eyes. It is due to the defect in the type 4 collagen. So children may present with hematuria and progressive kidney dysfunction. There is no specific management for Alport, but it is mainly focused at delaying the progression. So we give ACE inhibitor or ARB, and eventually the child might need renal replacement therapy. Next is congenital nephrotic syndrome. I think some of you might have many children with nephrotic syndrome, but congenital nephrotic is rare. It happens in infants less than 3 months of age. The prevalence is 1 to 3 cases per 100,000 live birth. This is often due to genetic mutation. So symptoms are similar to the late onset nephrotic syndrome. And treatment, we do not give steroid, but mainly supportive. Example, diuretics, furosemide, amiloride, ACE inhibitor, and NSAIDs, basically to induce a medical nephrectomy to stop the protein from losing. And subsequently, this group of children would require renal replacement therapy. And the last one is atypical hemolytic uremic syndrome. It is a genetic mutation that affects the complement system and cause activation of the complement cascade. Symptoms, a triad of symptoms like anemia, thrombocytopenia, and acute renal failure. Treatment would be plasma therapy, C5 inhibitor, or eculizumab may or may not require renal replacement therapy. So what are the diagnostic challenges in a rare pediatric kidney disease? The children might have non-specific symptoms like fatigue or poor growth, and the symptoms may be similar to other conditions like in nephrotic syndrome. It might mimic heart failure and liver failure. It can be asymptomatic in early stage. Some diagnostic tests are difficult to perform, like kidney biopsy. We don't do in a very small patients, right? Usually we wait until they are like 10 to 12 months. Various pediatric kidney disease, and it can overlap. So we might have difficulty in, diagnosing them. Genetic testing, it can be costly, time-consuming, and not always readily available. And not all genetic mutations are well understood. So this is just a nephrology point of view. Since today we're gonna discuss more about genetics. Why is it important to do genetic testing in pediatric kidney disease? It can provide a definitive diagnosis, especially in cases where symptoms overlap. Okay, and after getting the definitive diagnosis, we can tailor the treatment according to the patient's need. We can predict the disease progression, and we can do a little bit of genetic counseling and family planning discussion with the help of a genetic team. So what are the treatment options for the rare pediatric kidney disease? Same like any other diseases, conventional treatment or supportive treatment, medication, okay, diuretics, maybe this patient need a BP control, maybe lifestyle changes. Some of them would benefit from the novel therapies and emerging treatment like gene therapy, dialysis and kidney transplantation in advanced kidney diseases, and specific treatments for rare condition like cystinosis. We do give cysteamine therapy. So the challenges in managing rare pediatric kidney disease, the unique challenges in pediatric population like the growth and development. the emotional and psychological impact, not only to the child, but also to the parents. They need to take off from work frequently. They have other children and siblings rivalry. This all need to be to look into. And challenges related to multidisciplinary care required to provide individual and holistic treatment. So I'm going to share a few cases. Okay, I've got a case one, 20-year-old young lady and stage unknown cause since the age of 2. She had the first disease donor renal transplant at the age of 8. She had initial good graft function. However, 4 months later noted that there was a increment of the serum creatinine. So she had a biopsy done. It shows antibody-mediated rejection and her graft subsequently failed. She was fortunate to have a second disease donor renal transplant 6 months later. Same thing happened 7 weeks after transplant. And at this point of time, the biopsy actually showed thrombotic microangiopathy. She was given a course of plasma infusion and 4 doses of eculizumab, and her graft remained poor, and subsequently she needed dialysis again. This is the 3-generation family tree. She's the youngest out of 5 siblings. She had a brother who required dialysis, and the brother actually died during dialysis, and both the parents are fine. So based on the history, based on the biopsy findings, we think that this is a atypical HUS, and she was, I mean, we've got the chance to do the genetic study for AHAS. She has got 2 mutations, pathogenic CFH-R1 hybrid gene, and also another mutation, variant of uncertain clinical significant VUS at the CFI gene. So things that may have changed in the management of this child, maybe if we have known the genetic mutation early, this patient would not have undergone transplantation without eculizumab. Case 2, a 3-week-old Indonesian baby girl presented with a sepsis-like illness. She was less active and had reduced oral intake. She was born full-term at 38 weeks with birth weight of 2.5 kilo. Antenatally in utero growth parameters were okay. Parents were non-consanguineous with no family history of concern. This is the 2-generation family tree, and this is a second union for the mother. She has an elder sister who is actually well. So at presentation, she was ill, weight dropped from 2.5 to 2.2 kilo. She was hypotensive. She had no dysmorphic features. She had signs suggestive of dehydration. The respi and abdominal examinations were unremarkable. She had normal female genitalia. So investigations actually showed impact kidney function. Creatinine of 62 for a 1-month-old is quite high actually. She had a low albumin. The albumin was only 8, and she had a nephrotic range proteinuria where the UPCI was 10,000. So other causes of congenital infection apart from the genetic mutation, it could be a touch infection. Okay, so we screened for that. It came back as negative. She had a karyotyping done. So basically, it's just a cheap way of saying, oh, is this a WT1 mutation, not WT1 mutation? So phenotype was a female and the karyotype 46XX. So it is not ambiguous, you know, not a pseudohermaphroditism or ambiguous genitalia. And we were not able to do a genetic screening for her for CNS because it is quite costly and parents could not afford that. So for this girl, things that may have changed, if we are able to do the genetic study, we can actually, you know, advise the parents to a genetic counseling if it is positive for congenital nephrotic. Maybe we can, you know, predict the disease progression. We can tell the parents, oh, you know, she is gonna need dialysis maybe at the age of 4 to 5 years old. So they can prepare themselves for that. Mom is currently pregnant. So although you know that this is congenital nephrotic syndrome, it is related to genetic mutation, but we don't have the black and white to tell the mom that, hey, you know, so it is a bit difficult here. Case 3 is a 1-month-old girl. She was born at 33 weeks of gestation with birth weight of 1.7 kilo. She had an ultrasound for screening as the twin sister had hypertension, and the ultrasound showed features of ARPKD, multiple small renal cysts. Her parents' kidney and liver ultrasound were done. Again, this is also a cheap way of excluding ADPKD. And this girl developed hypertension a few weeks later, requiring escalation of antihypertensive. She was discharged with 5 antihypertensive. So this is the ultrasound images of hers. Can see multiple small cysts in the kidney on the right-hand side picture. But for her, the reniform configuration is still preserved. So similar to the previous case, things that may have changed, maybe if we can confirm the diagnosis, if this is a real ARPKD, we can do a bit of genetic counseling, we can actually predict the disease progression, we can prepare the patient for the next step of treatment. We know that eventually the kidney gonna deteriorate and should prepare them for renal replacement therapy. So future directions and hope for pediatric kidney disease. Number one is genetic research. If we can do more of genetic testing and personalized treatment according to the disease, it will be better. Gene therapy, now more towards PKD and LPOT. At least we can restore some portion of the kidney and sustain its function. That would be better. Other than that, regenerative medicine, early detection and screening in children, improve dialysis and transplantation, especially in children. Okay, maybe we can, shorten the duration of dialysis, maybe. Okay, or maybe we can do transplantation with a lower body weight. Like currently Malaysia is doing 17 kilo minimum weight, but in the Scandinavian countries, about 5 kilo. Maybe we can get involved in clinical trials and new medicine, and global collaboration, it would be beneficial. So in conclusion, early detection and intervention are crucial in managing pediatric kidney disease to prevent long-term complications and improve the overall outcome. A variety of common and rare kidney conditions affect children, and advances in genetic research and emerging therapies such as gene therapy would help us in providing more effective treatment in the future. Comprehensive care, multidisciplinary approach would be beneficial to the children. I think that's all from me. Okay, thank you so much.
All right, thank you very much, Karmila. Appreciate your talk, short and sweet, so that we have a lot of question and answer session. I think this is the exciting part. So I'll take the first question from, I think this is Dr. Cheng Shenfeng, adult nephrologist. So he's asking, how much does the genetic testing cost and how widely available is it? I know Dr. Tay, you can contribute as well if you want to answer, but we'll ask Prof. Karmila first.
Okay, usually I will consult Tay, but generally I think for me it will be quite expensive. Like for AHAS, the genetic mutation study, it costs the patient 1,900 pounds. So it is roughly about 12,000 ringgit.
Pound.
And yeah, it is 1,900 pounds, so roughly about 12,000 ringgit. They don't only do the genetic part, also, but also the complement levels. The rest, I think maybe they would know better.
Segue into your segment later on, Dr. Tay. So you want to answer now? It's okay as well.
It is frozen.
Hi. Sorry, I think my connection really has some. Yeah, it's frozen. Can you all hear me?
Can,
Yeah,
I can,
yeah.
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 Can. Oh, sorry, my connection really. Oh, okay. So it really depends. To answer Dr. Chen, it really depends on what is your working diagnosis and what tests are you talking about? Because there's no one test fit all. So for example, if we are talking about monogenic condition, and later I will share more during my presentation, but if let's say if we are thinking about some exome-based kind of sequencing, now the price is actually kind of coming down. It ranges roughly about 1,008 to 2,000 ringgit Malaysia. But again, like it really depends on what are we looking at.
Okay. Okay, that's
That answer?
basic answer. Okay, thank you. Dr. Tay will explain more in her presentation later on. Karmila, can I ask, so nephrotic syndrome adult, it's easy to see. You have a leg swelling, you have a puffy face, but for children, they all have puffy face.
They do. They do. I think
Yeah.
it's
So
quite
how does the
straightforward.
parents detect usually? I mean,
Oh, okay. Because they are quite puffy, so usually they
puffy
keep the
as in
patient for
children,
about a
all
week.
babies are like all gabu and everything, you know. So
You
sometimes it's difficult to detect.
Okay, you're talking about infantile nephrotic. Infantile nephrotic is a bit difficult to detect, especially in the first few months of life where they would present with signs of dehydration first, but later after after some time, later infancy or late early childhood, they would present with facial puffiness. They would present with progressive body swelling. Yeah, they know that their children are swollen.
Okay.
Yeah.
Perhaps. I think it must
Mm.
be sad for the parents as well to see that.
But
Um,
simple nephrotic is
with
kind of easy
uh,
to treat. Simple nephrotic,
okay,
but congenital
okay.
nephrotic is not. Yeah.
Would 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 it be true to say that genetic or chronic diseases because of genetic abnormality would be more difficult to treat and maybe having worse outcome compared to, let's say, acquired diseases?
Okay, it is difficult to treat. It depends on the disease itself. Okay, if
Okay.
this is Alport, we know that there is no specific treatment for Alport. It's just a supportive
Mhm.
treatment. So you know that eventually that this patient would progress to end-stage kidney disease. To treat is, I know we try to reduce the amount of proteinuria. Maybe it can be a bit tricky, but with transplant, they do better. The outcome of the
Okay.
transplant is better compared to immune-mediated disease. For AHAS, to treat is difficult, right? Not because we don't have treatment for it, but it is so expensive. The cost of treatment is like, a bomb. Imagine if, let's say, you need 3 vials of eculizumab, one vial is 6,000, 6 times 3, about 18,000, and you need it every month, lifelong. So I think that part is a bit difficult. And let's say if the kidney progress to end stage, if the patient require kidney transplant, you need eculizumab backup. It depends on the genetic mutation. If this is a CHH mutation, the risk of relapse is 80%, 90%. So it depends
Okay.
on the disease itself.
It strikes me when you mention about, let's say all these diseases, Alport, and for adult we have a ADPKD, to tell the parents that their kids eventually will require some sort of a renal replacement therapy and or transplant. How does it feel, or how do you prepare, or how do you prepare the parents and the doctors and the patient to this kind of an inevitable outcome?
Um, they do a lot of readings. Nowadays, everything is Googleable.
Mhm.
So they kind of know before they see you.
Okay.
Even when you see the diagnosis, they are well read. They know about the disease so well. So I think nowadays it is not as difficult as last time.
Okay.
So we just get other people to be involved as well, like genetic and palliative. So when we coming together, I think when we talk to the parents, different angle, so they are kind of okay.
Okay. We welcome all the participants who ask questions as well. We can answer live or type the question. Another question regarding Alport. So usually they presented with, as you say, hematuria or blood in the urine. So in adult, usually we'll do CT scan as well on the top of ultrasound just to see whether there is any stone or something like that. How much radiation would you be willing to expose the children to in this kind of investigation?
For us, hematuria, we don't do CT.
Mhm.
But some patients, if they need, like this kind of imaging, we are okay. And when we have to do, we have to do. But for hematuria itself, no, we don't do CT. What do? We screen for other causes of hematuria. If let's say we are worried of the stone, we do ultrasound and we do, calcium creatinine ratio, uric acid, and other common causes of stone analysis. We don't routinely do
Okay.
CT
All right.
scan.
Okay. So
Yeah,
there's a thing that we do in adults that we
yeah,
have some
we do.
reservation in children, obviously.
Mm.
Okay. So we have another question. As for your first case, retrospectively, does the patient need maintenance with eculizumab? So this is about your case, first case, asked
Oh,
by Maisara,
yes.
which is our nephrologist as well.
Oh, hi, Maisar. Hi, Maisar. Okay, yes, we do. We need to give eculizumab because of the genetic mutation, right? She has got the pathogenic mutation of the CFH1 hybrid gene. So we need to stand by eculizumab. In fact, we have to give prophylaxis eculizumab before the transplant itself.
Okay. And I think my last question, if other people don't have any question, you mentioned in our future treatment for PIDs, including regenerative medicine. I saw in I saw in the clinic recently about stem cell therapy and all those kind of thing. How much are we in the technology or in the state of things that we have advanced in that stem cell therapy?
I think for kidney is still under research, right? Preclinical study and clinical trial. So we are not there yet. But I'm not sure, but we are going towards that, the gene therapy and the stem cell therapy. Yeah.
But we have heard that, like, I think during my training 20 years ago, we heard about stem cell therapy.
But
And now 20 years down the line, I don't see much of a movement, at least
yeah,
in the nephro point of view.
yeah, I think, I don't know, in pediatrics, so far we have not used any stem cell therapy yet. But when I read, it is still at the preclinical study and also in clinical trial in nephrology. So I am
Okay.
really not sure, but I hope that one day we can progress in that field.
Okay. All right. So
Mm.
let's thanks Associate Professor Dr. Karmila for her wonderful talk and wonderful question and answer session. So